blood pressure was 160/95, and thiazide therapy was begun. Her only other medication is aspirin. She is 5'2". BMI is fine. Oh, today her pulse is fine. BP is 155/92. And her right, in the right upper extremity, and 153, so still high in the both extremities. Reminder of the exam is fine. Sodium is super low. Potassium is low. Chloride is low. Bicarb is normal. Calcium is normal. Urea normal. Glucose normal. Creatinine normal. Which of the following is the most appropriate next step in pharmacotherapy?
Okay, hyponatremia or serum sodium concentration less than 135 may be acute or chronic with symptoms related to the severity of depletion and the abruptness of onset. Acute decreases in sodium acute decreases in sodium concentration may lead to neurogenic acute acute decreases in sodium may lead to neurologic symptoms such as seizure altered mental status caused by cerebral edema caused by cerebral edema. Chronic hyponatremia in contrast that leads to less severe symptoms such as nausea, vomiting, lightheadedness, fatigue, and confusion. One well-known cause of significant hyponatremia One well-known cause of significant hyponatremia is the initiation of the diuretics, with other causes including adrenal insufficiency, volume overload, and the syndrome of an inappropriate antidiuretic hormone secretion. This patient was recently started on hydrochlorothiazide. This patient was started recently on hydrochlorothiazide, shortly after which the symptoms began, making her hyponatremia most likely secondary to thiazide diuretics. Therefore, the most appropriate next step in pharmacology is discontinuation of the hydrochlorothiazide.
15 girl brought to the office by her mom because of a 3-day history of pain with urination and increased frequent and urgent need to urinate. She has had 3 episodes of UTI during the past year. She has no other serious illness, no medication. Patient appears subdued and avoids eye contact. The physician asked the mom to leave the office for the remainder of the interview, and she initially is reluctant. When she leaves the room, the physician asks the patient about sexual history. The patient appears anxious and asks, "If I answer the question, will you promise not to tell my mom?" Which of the following is the most appropriate physician response?
Okay, inform the patient that her information will be shared only if her safety or that of others is at risk. The physician is obligated to protect patient's confidentiality even if the patient is adolescent. Exceptions to adolescent confidentiality are permitted in situations of child abuse, suicidality, homicidal ideation, certain cases related to sexually transmitted infection, healthcare, mental health care, and in some state when a patient consents to an abortion. Each state has a varying statutes regarding confidentiality. Physicians should be familiar with the statuses in their area. This patient reports symptoms of frequent urinary tract infection, which may indicate consensual sexual activity or sexual abuse. The physician has an obligation to promote the patient's best interest by inquiring about sexual activity or potential abuse while also maintaining honesty about the limits of confidentiality.
You read A, B, and E.
Yeah,
A, B, E.
yes. Asking the patient why she is concerned about confident asking the patient why she is concerned about confidentiality is likely to make the patient defensive and will reduce the likelihood of obtaining truthful information. Empathizing with patients' desire to keep her sexual history private is an important component of fostering a therapeutic relationship, but does not directly address the patient's question about confidentiality. And reassuring the patient that the need to break confidentiality about her health is unlikely and is inappropriate, as the physician does not yet possess adequate information to make this determination. In the setting of sexual transmitted infection or child abuse, it may be necessary to break the patient's confidentiality, and the patient must be informed of this possibility.
37 men with 2 year history of intermittent right knee pain comes to the office because of a 2 month history of increased knee pain that began after he collided with another person while skiing. The pain has particularly worsened during the past 2 days and has made bearing weight on his right leg difficult. Immediately following the collision, he felt a sharp pain in the middle of his kneecap and sustained several scrapes and cuts on his kneecap. Okay. Which stopped bleeding within minutes but have continued to slowly ooze and clear discharge. Medical history is fine. The only medication is daily multivitamin and occasional acetaminophen for the pain. Temperature is high, pulse is normal, BP normal. Exam shows maybe a bit low. Exam shows red right knee. That is one to touch. Patella is palatable and there is moderate joint diffusion. Bending of the right knee, uh, 10 to 15 degrees causes pain. The patient cannot tolerate bending any further. Which of the following is the most likely diagnosis?
Okay, it's pyogenic or septic arthritis, presence with painful erythematous swollen joints, painful erythematous swollen joints along with systemic signs and symptoms of illness such as fever, chills, myalgia, arthalgia. Septic arthritis results from a bacterial infection of the synovial joint space, most commonly by the Staph aureus. This patient's septic arthritis was likely caused by traumatic arthrotomy that permitted introduction of bacteria and explains the persistent fluid leakage, likely synovial fluid. On physical examination, the affected joint shows swelling, erythema, and pain with passive range of motion. Arthrocentesis is indicated for the evaluation of monoarticular erythema and swelling to evaluate for septic arthritis, which characteristically shows purulent synovial fluid with greater than 50,000 leukocytes. Serum studies may also show leukocytosis and increased inflammatory markers such as C-reactive protein ESR. Treatment involves urgent IV antibiotics and source control with patients often requiring irrigation of the joint in the operating room to treat infection and limit further acute and chronic inflammation. Okay.
Can you read C and E? CE.
Yes. Patellar tendonitis or inflammation of the patellar tendon can occur can occur as an overuse of can occur as an overuse injury and presence with pain inferior to the patella during physical activity, climbing stairs. Pain inferior to the patella during physical exercise, climbing stairs, rising from a chair. It would not likely present it would not likely present with a joint diffusion or fever. Synovial chondromatosis is a rare disease in which synovium produce nodule or cartilage. This can cause early osteoarthritis or joint pain, but a patient presenting with fever and joint diffusion is more likely experiencing septic arthritis. Okay,
Okay. Yeah. Next. 15 girl brought to the office because 2 week history of facial rash and fatigue. She has had 9 day history of stiffness and swelling of her fingers. On awakening in the morning, she
what
has no
is your
history of
diagnosis?
mm, the lupus.
Yes, sparing the nasolabial fold.
She appears tired and asthma, chest pain with inspiration. Temperature high, pulse normal, respiration normal, BP normal. Photograph of the patient is fine. There are three non-tender ulcers over the soft palate. Diffuse 1 to 2 centimeter lymph node are palpated in anterior and posterior cervical chains. Lungs are clear, hearts are normal. Exam of the extremity shows mild redness, tenderness, and swelling of proximal interphalangeal and knees and metatarsus, whatever. The analysis shows 2 plus protein and 1 plus blood. Which of the following is most appropriate in determining which of the following is most appropriate in determining management for this patient?
Okay. So renal biopsy should be done. Mm, SLE is an autoimmune disorder with a wide range of signs and symptoms, including malar rash, photosensitivity, discoid rash, painless oral ulcer, arthritis, serositis, kidney impairment, hematologic abnormalities, hemolytic anemia, leukopenia, lymphopenia, thrombocytopenia, and abnormal anti-nuclear antibody titers or lupus-specific antibodies, anti-DNA, anti-Smith, antiphospholipid antibody. This patient has numerous of these criteria suggesting a diagnosis of the SLE. Lupus nephritis is a complication of the SLE is common in younger women. In younger women, common in younger women, it presents with hematuria and increasing creatinine in the setting of SLE. Evaluation of the lupus nephritis requires renal biopsy in order to accurately determine the type and the extent of the renal biopsy type and the extent of the renal involvement. This information is vital for optimizing the treatment of nephritis. For example, immunosuppressive therapy is warranted for active diffuse or focal proliferative lupus nephritis, but not mild mesangial or mesangial proliferative lupus nephritis. Okay,
67 woman comes physician because 6 month history of mild pain in her legs with walking and rest. Hmm,
what is your diagnosis?
that how do you call that? The
Varicose vein.
varicose veins. Yeah. Her pain is somewhat relief when she elevates her leg. She has 3 year history of intermittent swelling of the legs. She has no history of serious illness, no medication. She smoked for 18 years. She has been able to perform her normal daily activities. Cardiopulmonary exam is fine. There is no pitting. There is non-pitting edema of the lower extremities. Photograph of the right lower extremity is shown. Which of the following is the most appropriate next step in diagnosis?
Chronic venous insufficiency frequently occurs with age as a result as a result of combination of the venous reflux, incompetent valves, venous hypertension, and decreased muscle function. Risk factor for developing include early age, prolonged standing, obesity, tobacco use, and a family history of venous disease. Patient may be asymptomatic, but when present, symptoms include leg heaviness, pain, cramping. Physical examination may show a varicose or dilated veins, non-pitting edema, or lower extremity discoloration, as well as ulceration if the insufficiency is severe. Diagnosis is clinical. Diagnosis is clinical, although venous duplex ultrasonography can be used. If the diagnosis is unclear, treatment is initially conservative and include exercise, compressive stockings, and leg elevation. Symptomatic patients can undergo venous ablation, sclerotherapy, or other surgical intervention. This patient has chronic leg pain associated with varicose vein evaluation, making venous insufficiency the most likely cause. No further evaluation is indicated.
Here is B and D.
Lymphangiography is used to evaluate the lymphatic. Lymphangiography is used to evaluate the lymphatic system. It is used to determine whether cancer has metastasis to nearby lymph node or in the diagnosis of the lymphedema. This patient has signs of venous insufficiency rather than lymphedema, making lymphangiography is inappropriate, making lymphangiography an inappropriate next in diagnosis. And D.
Mm-hmm.
Angiography of the lower extremities is not necessary for diagnosis of the venous insufficiency. It is more common used to evaluate the arterial system, especially in the diagnosis of the peripheral artery disease, especially in the diagnosis of the peripheral artery disease or lower extremity aneurysm. This patient has no signs of arterial disease, making angiography unwanted. Okay.
10 days after undergoing above left above the knee amputation for severe diabetic soft tissue injection infection. 78-year-old man in the ICU has noisy labor breathing. His postoperative course has been complicated by sepsis, delirium, and respiratory insufficiency. Temperature is fine, pulse fine, respiration super low, BP low. Pulse oximetry, oxygen 92. He's not oriented to pace person on time. Breath sounds are close and distant. The extremities are cool to touch and mottled. After discussion with the patient family and consistent with the patient wishes, the family has chosen to provide comfort of care. The family remains concerned about the patient's current loud breathing and secretions. Which of the following is the most appropriate next step in management?
The family remains concerned about secretion. Patients, patients in the process of dying frequently experience difficulty managing airway secretion. while which is distressing for which is distressing both for the patient and for the family members. Pharmacological agents may be useful in reducing the production of ARS secretion. Commonly used is glycopyrrolate and scopolamine, both of which are anticholinergic drug. Glycopyrrolate may be preferable because of its inability to cross the blood-brain barrier limit. Central nervous system side effects such as agitation, delirium, seizures. Scopolamine is available a patch which advantages for patients with a compromised swelling, a compromised swallowing, or excess secretion. Non-pharmacologic method may non-pharmacologic methods of managing airway secretion during the dying process include suctioning, positioning the patient on their side, and reducing unnecessary IV fluid administration.
Okay, next. Previously healthy 4-year-old boy brought to the ED by his mom on a winter evening because of sudden onset of coughing and mild difficulty breathing. His symptoms began late this afternoon when he was playing with other children. At a party, his brother has asthma, temperature is, I guess, fine, pulse fine, respiration high, physical exam shows intense intermittent coughing, and mild intercostal retractions. Wheezes are heard bilaterally but are greater on the right. X-ray of the chest is shown. What is the diagnosis?
In X-ray, have you found anything?
No, there you can see the body or anything there.
Okay. Mm, this patient is presenting an acute onset of coughing. This patient is presenting an acute onset of this patient is presenting an acute onset of coughing, dyspnea, tachypnea, making aspiration of a foreign body the most likely diagnosis. Foreign body aspiration is common. Foreign body aspiration is common in children, especially those younger than 2 years old, especially those younger than 2 years old, and may be witnessed or unwitnessed. The most common location of the aspirated object is the right lung of the left main bronchus. Of the right lung of the left main bronchus leaves leaves the trachea at the sharper angle. Leaves the trachea at the sharper angle. These objects uh, these objects often lead to symptoms seen in this patient where subjects lodged in the trachea or larynx often lead to stridor, rapid hypoxia, cyanosis, even respiratory arrest or death. Physical examination in patient with foreign body aspiration may disclose stridor and wheezing with decreased air movement. Evaluation often includes chest X-ray, which will frequently show on the right side, hyperinflation on the side of the foreign body with a mediastinal shift towards the contralateral side as seen in this patient. However, most commonly the aspirated object is not identified on chest X-ray as it is frequently radiolucent subject. Thus, a high index suspicion is needed to make the diagnosis. Treatment includes removal of the foreign body with bronchoscopy.
Can you read B and D? BD.
Yes, um, congenital lobar emphysema generally presents by age 9 months with respiratory distress, tachypnea, cyanosis, as well as wheezing and decreased breath sound on physical examination. It causes hyperinflation it causes hyperinflation of a lobe of the lung, leading to mediastinal shift and the symptoms seen while the chest X-ray may be similar. Those seen with congenital lobar emphysema would be unlikely to present acutely at age 4 years. Laryngotracheitis Laryngotracheitis or croup presents with rhinorrhea, nasal congestion, fever that progress to stridor barking cough. Most commonly, most commonly as a result of viral respiratory illness, symptoms are secondary to narrowing of the subglottic airway, which can be seen chest X-ray, known as stipple sign. The patient does not have barking cough, stridor, or stipple sign, chest X-ray, making the diagnosis unlikely.
Okay. 62 man comes to office with his wife for follow-up. 4 weeks after he was hospitalized for management of acute MI that required cardiac catheterization, he has had 3 pound weight gain since yesterday, or since discharge, so 4 weeks. He has not had shortness of breath or chest pain on exertion, has been sleeping well. Medications are losartan, atorvastatin. He's intermittently adhering to regimen. He has had irregular attendance at outpatient cardiac rehab. He said he sometimes skips sessions because he's tired. His wife said he is irritable and often talks of his father who died of a heart attack, 65 years old. The couple has not resumed sexual activity because of the patient's fear of having another heart attack. The patient enjoys seeing his grandchildren but is no longer interested in playing poker with his friend. His BMI is, I guess, a bit high, normal. Pulse is fine, respiration fine, BP fine, physical exam shows no pedal edema, mental status exam, he describes his mood as blah and has constituted affair. He reports no suicidal ideation or suicide plan. What is the diagnosis?
What is your diagnosis?
Adjustment disorder.
Adjustment disorder is within 3 months, isn't it?
Mm-hmm.
An acute stress disorder from
The,
3 days to 1 month.
uh-huh.
Okay. Adjustment disorder refers to the onset of emotional disturbance within 3 months of an identifiable stressor. The emotional disturbance manifests as marked distress out of proportion to the stressor, and an significant impairment in daily school work or functioning. Patients may internalize or externalize their distress, resulting in symptoms of depression or anxiety symptoms or conduct disturbance acting out respectively. Patients with adjustment disorder do not meet the criteria for anxiety, major depressive and conduct disorder. This patient demonstrate some anxiety or depression symptoms, irritability, loss of interest, conduction, conduct disturbance, skipping cardiac rehabilitation sessions with prior identifiable stressor, and without meeting the criteria for anxiety, major depressive and conduct disorder. Such adjustment disorder is typically self-limited Appropriate treatment is brief supportive psychotherapy. Can you please explain with uh, because this type of disorder I got fixed when I read the question.
I
So
think,
what
yeah,
makes you like feel that it is adjustment disorder?
I think you can approach the question two ways. You can remove all the other ones and you would be left with that, with those two, adjustment and MDD. And then you know that it's not MDD because you know how to count the 5 out of 9,
Yes.
whatever. So start counting and you'll say that he doesn't really have the 5 ones. Um, or you can just, if you know adjustment is within 3 months, so this falls in between there. And then from identifiable stressor, the identifiable stressor is the MI, and then the surgery. And then that is causing some mood issues like depression or anxiety or issues with your behavior, like you're acting weird. So he has kind of like a little bit of issues with behavior because he's keeping his rehab stuff. He has depression symptoms, loss of interest, whatever, and he has anxiety. He hasn't had sex and all these things. So you can go through that. You can. So there are two ways you can kind of get to the answer here.
Okay.
Yeah.
So for diagnosing adjustment, first we need to find out a stressor,
Yeah, you need a
like
stressor.
like a real stressor, like
Yeah,
acute MI.
and it
Then the
doesn't.
then the timeline.
Then the timeline. It has to be. That's the difference between adjustment and generalized. Generalized, you don't need a stressor. And PTSD, you need a stressor, but the stressor needs to be like life threatening, mm, like accident. And then
And
PTSD,
like PTSD should be more than 6 months.
is it more than no? It's more than a month.
PTSD is more than a month.
Yeah,
Okay,
ASD is
great.
less than a month. PTSD is more than a month. Yeah. Yeah, so that would be PTSD. But PTSD, you also have the intrusive thoughts. So he'll be thinking, and here there are no intrusive thoughts and dreams about the accident and things like that. And he doesn't have all that.
Okay.
17, primigravida at 22-week gestation comes to the physician because of 12-hour history of fever, nausea, and vomiting. She has abdominal tenderness on the right side when she coughs. Her temperature is high. Pelvic and rectal show right side tenderness. Hmm. Beta heart tones normal, leukocyte count high, with shift to the left. Serum amylase activity is fine. During the next 8 hours, vomiting, fever, and abdominal pain continue. Ultrasound of the gallbladder shows no abnormalities. What is the most appropriate next step in diagnosis?
Is it torsion?
Is it?
No.
No.
Leukocyte count is high. Oh, wait, okay. Ovarian torsion may be confused with appendicitis.
Mm-hmm.
Okay. So it is acute appendicitis. So appendicitis presents classically. Appendicitis presents classically with the right lower abdominal pain and is often periumbilical at onset, nausea, anorexia, fever, leukocytosis, and tenderness to palpation in the next tenderness to palpation in the right lower quadrant examination. McBurney's point McBurney's point, a sensitive location for tenderness on palpation is located at two-thirds of the distance between the umbilicus and the inguinal ligament because this is the common position of the appendix. In pregnancy, the location of the enlarging uterus may cause appendix to be displaced superiorly and compared to that of a non-gravid patient. These displacement methods This displacement limits the classic history. This displacement limits the classic history and physical examination which rely on the right lower quadrant position of the appendix. When displaced scaffold, parietal, parietal peritoneal inflammation may no longer occur at the McBurney's point, even migrating as scaffold as the right upper quadrant mimicking diagnosis such as cholecystitis. Diagnosis is facilitated by CT scan, though less ideal in pregnancy due to the risk for teratogenicity to the fetus. MRI and or ultrasonography, which may show appendical enlargement and the presence of appendical wall thickening or periappendical fluid or fat stranding. Fetal heart rate tracing eh, are usually fetal heart rate tracing are usually reassuring unless maternal hemodynamic have been compromised. Fetal tachycardia may be result from the response of the maternal fever. Treatment is urgent laparoscopic appendectomy to prevent complications such as appendicular rupture, sepsis, or preterm labor. Okay.
You read A.
Yes. Barium enema. Barium enema is often used. Barium enema is often used to evaluate abnormalities on the rectum and colon, such as those in inflammatory bowel disease or colon cancer. The barium used allows the soft tissue of the GI tract to be more clearly defined on X-ray. Generally, X-rays are avoided in pregnant patients and given the risk for radiation exposure for the fetus.
Okay. Next. 18 men comes to the clinic because of 3-hour history of right eye pain with mild light sensitivity and blurry vision. And I have been present since he awakened this morning. He has no symptoms on the left eye. He reports being struck in the face by soccer ball last night but having no symptoms at that time. Medical history is fine. Is remarkable for admission to the hospital 2 years ago for acute chest syndrome secondary to sickle cell disease. He has taken hydroxyurea since then. He takes no other medication, does not wear contact lenses. Family history remarkable for glaucoma, the maternal grandfather. The patient vital signs are normal. Exam of the right eye shows blood filling the lower 20% of the anterior chamber. Pupils are equal and reactive to light and accommodation bilaterally. Visual fields are intact. Visual acuity is 20/60 in the right eye and 20/20 in the left eye. Intraocular pressure is 27 in the right eye and so it's high in the right eye and normal in the left eye. Which of the following factor in this patient most strongly increases his risk of complications for his current condition?
Okay. So hyphema, the accumulation of blood under the accumulation of blood in the anterior chamber may occur following blunt ocular trauma surgery spontaneously in the setting of von Willebrand disease, hemophilia or leukemia, or anticoagulant use. In the setting of trauma, ifema occurs as a consequence of uh, damage of the anterior chamber angle, iris root, or ciliary body, which are rich only vascularized. Immediate and subacute complications of ifema include ocular hypertension, which may lead to glaucomatous optic nerve damage, rebleeding, and corneal blood staining. Corneal blood staining may significantly impair visual acuity and may necessitate a corneal transplantation if the central cornea is involved. If the central cornea is involved, chronic complications of ifema are primarily related to glaucomatous damage to the optic nerve. Ifema is particularly dangerous in patients with sickle cell disease or trait because of complication of red blood cell sickling. Sickled RBC in the anterior chamber, sickle RBC in the anterior chamber are less likely to be filtered through the trabecular meshwork and are likely to result in ocular hypertension. Ocular hypertension may then induce sickling of the RBC in the retinal vasculature, leading to irreversible vision loss through induction of retinal through induction of retinal or venous occlusion. Are most hyphema may be managed medically through topical drugs mm, to lower ocular pressure in patients with sickle cell disease or trait. Surgical anterior-chamber washout is indicated if intraocular pressure is not controlled within 24 hours. In patients without sickle cell disease or trait may tolerate high intraocular pressure for up to 5 days before surgical washout may be considered. Okay.
Okay, next. Previously healthy 16-year-old boy comes to physician because of constant right side scrotal pain for 36 hours. He had sexual intercourse with a new partner 1 week ago. Temperature is high, abdominal exam is fine. There is scant penile discharge. The right scrotum is swollen tender, especially posteriorly. The pain is less severe when the scrotum is elevated. Urinalysis, gram stains of urethral discharge show leukocytosis. Which of the following is the most appropriate step in management?
Okay. So epididymitis presents with fever, dysuria, urethral discharge, and tenderness, erythema, fullness of scrotum. Men between the to decade of life are most second to fourth decade of life are most commonly affected. The most common cause of organism is Chlamydia trachomatis, followed by Neisseria gonorrhoeae. Characteristics: clinical feature of epididymitis include preservation of the clinical feature of the epididymitis is preservation of the cremasteric reflex in addition to cremasteric reflex, in contrast to the absence in the setting of testicular torsion, a positive prehensign in which testicular pain is alleviated by elevation of the testis, and normal Doppler ultrasonography findings of the testis through hypervascularity may be noted in case of epididymoorchitis. Doppler ultrasonography is most useful when testicular torsion is suspected. However, This patient's presentation is consistent with epididymitis. So the most appropriate next step is to initiate antibiotic therapy to prevent potential spread of the STD, sexually transmitted infection, and to ease symptoms. Most patients experience resolution of these symptoms mm, resolution of the symptoms with antibiotics including azithromycin, ceftriaxone, and symptoms relief with non-steroidal anti-inflammatory drug, rest, scrotal support, and ICE follow-up. Nucleic acid amplification testing is needed to identify causative organisms such as Chlamydia trachomatis and Neisseria gonorrhoeae, and screening for concomitant sexually transmitted infection such as syphilis or HIV. Men over 35 or those who are unprotected and anal insertional intercourse are commonly infected by E. coli and opposed to Chlamydia trachomatis or Neisseria gonorrhoeae. Okay,
Next. 52 woman comes to the physician because 1 week history of increasingly severe pain and swelling of the right knee. She is now unable to walk because of symptoms. 5 years ago, she fell and hit the knee on the bathroom floor. She has hypertension treated with lisinopril, temperature fine, pulse fine, respiration fine, BP fine. Right knee is red, swollen, and warm. There is diffuse tenderness to light touch, passive and active. Range of motion is limited by pain. There is no crepitus, but ballotment shows moderate knee effusion. Arthrosynthesis is performed in joint. Fluid analysis shows leukocyte counts 50,000. Gram stain is negative. Rhomboid shaped crystals are present.
what is your
X-ray
diagnosis?
chondrocalcinosis or something like
Rhomboid shaped crystal for pseudogout and
pseudocal. Yeah.
and positive bifringent crystal, which is rhomboid shape, it is pseudogout, and negative bifringent crystal, which is needle shaped, it is gout. Okay,
Mhm, mhm.
okay. Then pseudogout result from calcium pyrophosphate crystalline deposition the with within the second joint space. Manifest acutely following trauma, surgery, exertion. Crystalline deposition provokes the inflammatory response leading to the classic presentation of the joint pain, erythema, infusion, calor, and reduce the range of the motion. Pseudogout most commonly affects the knee. Orthosynthesis is diagnostic as it allows for sampling of the synovial fluid, which shows the presence of calcium pyrophosphate crystal and increased concentration of the leukocytes. Additionally, arthrosynthesis is necessary to rule out the presence of septic arthritis erythematosus, given the patient's presentation of monoarticular erythema and swelling. These competing diagnoses can be excluded on clinical features alone. Plain film X-ray may show chondrocalcinosis and degenerative joint changes. First line medication. First line management include NSAIDs such as ibuprofen and colchicine. Okay.
Okay. 28 woman comes to office for follow-up exam 2 weeks after undergoing total thyroidectomy because of thyroid nodule. Immediately after the operation, the patient had the onset of mild hypocalcemia and was admitted to the ICU. During the hospital stay, IV calcium and calcitriol were given. Today, she has had recurrent numbness around her mouth and muscle cramping. Current medication, calcium carbonate 3 times daily with meals and calcitriol twice daily. Vital signs normal. Physical exam shows spasm of the ipsilateral facial muscles when tapping anterior to the ear. Reminder of the exam is fine. Lab studies are most likely to show an increase in which of the following in this patient increase.
Okay. So what is your diagnosis?
Mm, are those the signs of hypocalcemia? Or are those, yeah, hypocalcemia, right? Because they remove the thyroid, so they probably remove the
And
parathyroid.
there is like you have seen like Vostick sign, uh, like spasm in the ipsilateral facial muscle. This is called Vostick sign. Chin in the Vostick sign, and in the BP cuff there is Trosso sign. In the hypocalcemia,
Mm-hmm.
okay, a hypocalcemia is a common, like he removed the parathyroid gland during thyroidectomy. That's why it happened, isn't it? Okay.
Mm-hmm.
Hypocalcemia is a common complication following thyroidectomy as a result of resection of the parathyroid gland. As a result of resection of the parathyroid gland, parathyroid hormone along with calcitriol, parathyroid hormone along with calcitriol regulates calcium homeostasis. PTH is secreted in response to PTH is secreted in response to low calcium concentration and acts to rise the concentration by increasing bone resorption, promoting production of the calcitriol to increase intestinal absorption of the calcium and increasing calcium resorption in the renal tubule. Patients with hypoparathyroidism will have an increase in urinary 24-hour calcium excretion as a result of the loss of the resorption stimulation in the kidneys, requiring the daily calcium supplementation. Symptoms of hypocalcemia include perioral paresthesia, cardiopedal spasm, laryngospasm, prolonged QT interval. The Vostick sign is like tapping the facial nerve to spasm of the facial muscle, and Trousseau sign in this, in which inflated blood pressure, cough occluding the brachial artery causing carpopedal spasm, are two physical examination findings that may indicate hypocalcemia. So we need, like, after the thyroidectomy, if this, like this hypocalcemia is present, then we need to see the urinary 24-hour calcium excretion.
Mm-hmm.
If we see the serum calcium level, isn't it enough?
But no, they're asking what lab will be increased. The serum calcium will be decreased, right? The question is
Oh,
what
okay.
lab will be
Lab will be
increased.
increased. Okay,
Mm-hmm.
okay, urinary calcium. Okay.
Next, previously healthy 27 woman comes to the physician because of rash over chest and back for 5 days. She has 10-day history of pain with urination, urinary frequency, nocturia, 2 to 3 times nightly. She took her father TMPSMX for 7 days, and her urine systems they improved. So she had the urination, then she took the medicine, now she has she couldn't take no medication, no cigarettes, temperature fine, pulse high, respiration fine, BP fine. Exam of the skin shows erythematous macular papular rash over the trunk. There are no lesions. There is no splenomegaly, labs, hemoglobin, bit low, leukocyte fine. Eosinophils, I think is high. Basophils, I think is high. Let me double check. eosinophils high, basophils high, lymphocytes high, monocytes high, platelet count normal. Which of the following is the most appropriate next step in management?
So it is drug-induced neutropenia, isn't it?
Oh,
Neutrophil
because
count is low.
okay.
Neutrophil low. Leukocyte count is low.
Mhm.
Normally, neutrophil may be 55 to 65 or 75. So, neutrophil low, leukocyte low. It looks like drug-induced neutropenia, one of the most common idiosyncratic drug reaction reported. A large number of medication are associated with adverse effect. Neutrophils normally account for approximately 40 to 60% of total white blood cell count. Total white blood cell count on a complete blood count. This patient has an abnormally low count in the setting of recent trimethoprim sulfamethylcetol. Recent trimethoprim sulfamethylcetol use for the treatment of urinary tract infection. She does not have other apparent risk factors of a personal or family history of hematological disease. The patient most appropriate next step in the management is to repeat examination in a week with a repeat common blood count with a repeat complete blood count. Neutropenia in adult is often secondary to drug reaction. Infections, malignancies, direct toxin include chemotherapy. Antibiotics are commonly implicated in drug-induced neutropenia. Most cases will resolve within days or 2 weeks after discontinuation of the offending drug. Okay.
Yeah. Next. 57 woman who was admitted to the hospital because of pneumonia has had an increase in serum creatinine concentration from 1 to 2.4 during the past 3 days. On admission 7 days ago, she had severe shortness of breath, hypotension. She was intubated, mechanically ventilated for 2 days. 6 days ago, a CT scan of the chest with contrast showed pneumonia, both lungs. She also has type 2 diabetes, current medications, ceftriaxone, azithromycin, albuterol, insulin, lisinopril. She is now breathing through oxygen via nasal cannula and has mild shortness of breath. BP has been stable for 6 days. Urine output has been 1 liter per day during the past 2 days. Um, Her pulse is fine. BP is high. Pulse oximetry oxygen is 94. Crackles are heard at both lung bases still. Urinalysis, protein 1 plus, RBCs a lot, white blood cells a lot, cast none. Okay, a right stain of the urine shows eosinophils. Which of the following is the most appropriate next step? Hmm.
Acute interstitial nephritis caused by hypersensitivity reaction of the medication, non-steroidal anti-inflammatory drugs, diuretics, sulfonamide, rifampin, PPI, proton pump inhibitors, and antibiotics. Infections or autoimmune disorders such as sarcoidosis, SLE. Patients may be asymptomatic, but common signs and symptoms and lab findings include rash, sterile pyorrhea, hematuria, or eosinophilia. Patients may have proteinuria, but typically not the extent of nephrotic syndrome. Eosinophils are often detected on urine analysis as seen in this case. Acute interstitial nephritis complicated by the acute kidney injury and a decline in kidney function. Treatment of AIN include supportive care and discounting. Treatment of AIN includes supportive care and discontinuing the casual medication where there is one, in this case ceftriaxone.
Okay.
Okay.
Okay. Next. 40 men comes to the ED because one day history of nausea and vomiting. He has had no fever, chills, abdominal pain, diarrhea. He says taking a hot shower alleviates the symptoms. He has no history of serious illness, doesn't take medication. He says he occasionally uses illicit drug but refuses to provide any information. Temperature normal, pulse a bit high, respiration normal, BP, I guess high. Exam shows no abnormality. Intoxication from which of the following is the cause of this patient condition?
What is your diagnosis?
I guess it's cannabis.
Why?
Mm,
Like only present nausea and vomiting.
I think I just did this with my tutor yesterday. This taking a hot shower alleviate is like a clue of
Okay.
this. Oh,
So
wait, let me get it.
taking hot shower like alleviates symptoms only in cannabis.
Let me get my notebook because I just did that. Yeah, he went through all the because I told him I had the issue with those drugs, intoxication drugs, and he went through all that. And I'm pretty sure he said something about inhaling. Which one is it? Cannabis. Yeah, conjunctival injection, increased appetite, dry mouth.
And no, nothing is present. Like conjunctival injection, cognitive slowing, increasing appetite, hallucination, paranoia. Nothing is present. Only thing present in this question like vomiting. So
Oh, there
cannabis,
it is.
sorry.
It, yeah, it says cannabinoid hyperemesis syndrome. The
Yes,
patient,
it. This is written here. Yes.
yeah, it's the abdominal pain and vomiting that's relieved by hot showers. Okay. In patients that regularly smoke cannabis. Yeah.
So hot shower relieve the symptom, and there is cannabis hyperemesis syndrome. These 2 point is important. Okay.
Oh, can you read
Oh,
it? Did you read it? Okay.
sorry.
Did you already read it? Can you read it?
No, no, I am just excluding my options. Okay.
Ah, your options. Okay.
Cannabis is an hallucinogen, can cause euphoria. Cannabis is a hallucinogen can cause euphoria, paranoia, hallucinations, increased appetite, conjunctival injection, cognitive slowing. Chronic cannabis can lead to chronic cannabis can lead to cannabis hyperemesis syndrome, which is characterized by episodic vomiting associated with prolonged, frequent, high-dose recreational cannabis use. Patients often find relief with hot water bathing. It typically resolves after cannabis cessation. And if we read the other options like chronic cocaine use,
Mm-hmm.
cocaine can cause like anosmia, cognitive impairment, delusion, hallucination. Cocaine can cause like uh, pupil dilation, isn't it? Cocaine,
Mm-hmm.
amphetamine.
Mm-hmm.
Okay. Heroin like opioid, constricted people, bradycardia, hypertension. Okay. LSD is a hallucination. So LSD visual hallucination, depersonalization, flashback, paranoia. LSD. And methamphetamine Amphetamine is again the hallucination, delusion, hallucination, and dilated people.
Let me see if you said anything about LSD specifically that can help you.
Is there any clue like in LSD?
Yeah, I feel like he gave me a clue for LSD. Let's see if I can find it. I feel like he did give me a clue. LSD. Never mind. If I found it, I'll give. I feel like it because he gave me a clue for each one.
Okay.
Hmm.
And PCP for nystagmus, rotatory nystagmus,
PCP was the nystagmus and the violent behavior. That one I
violent
remember.
behavior. Okay. PCP is nystagmus, violent behavior. And amphetamine is dilated people, delusion, hallucination. LSD for visual hallucination. Okay, got it.
The next one, look. Uh, 62 woman comes to the physician because 4-month history of painless mass in her left breast. The mass has not changed in size. 10 years ago, she had a total abdominal hysterectomy with bilateral salpingoforectomy. As a protection with hypertension treated with thiazide, her maternal aunt was diagnosed with breast cancer at 55. The patient vital signs normal. Exam shows a 2.5 centimeter hard immobile mass in the upper outer quadrant of the left breast. Mammography and fine needle aspiration biopsy specimen shows no abnormality. Next step in management.
Okay. Excisional biopsy, breast cancer, the most common non-dermatologic malignancy in women, typically consists of two main histologic subtypes. Ductal or lobular adenocarcinoma can present with breast mass or axillary lymphadenopathy. Risk factors for development include exogenous estrogen use, family history of breast cancer, genetic mutation, early late menopause, nulliparity, obesity, African American ethnicity in patients over age 30 years with a palpable breast mass or axillary lymphadenopathy. Mammography should be the first step in the diagnosis. Other radiologic evaluation may include ultrasonography to identify a lesion suitable for biopsy. However, regardless of imaging findings, biopsy should occur if the physical examination is concerning for breast cancer, as it is in the patient. Fine needle aspiration only has severity of the approximately 74%, and as not the sample obtained and adequate for diagnosis. Thus, this patient with high risk lesion or physical examination should undergo more sensitive diagnostic evaluation with excisional biopsy, which would remove the whole mass for analysis and may be curative if disease remains confined to the lesion. Okay.
Can you read C and D?
MRI of the breast is not typically used. MRI of the breast is not typically used for breast cancer. Most commonly, it is used to evaluate the extent of the disease. It is uh, extent of the disease in a newly diagnosed breast cancer as a screening modality for those with increased risk for developing breast cancer. It is not the most appropriate next step in the management for this patient. It would not provide a tissue diagnosis. It is more frequently for cancer screening in a younger woman with dense breast tissue for whom mammography may be less sensitive. Tamoxifen therapy is mixed estrogen receptor agonists and antagonists used to treat in the breast cancer. These patients should not be treated for breast cancer without a formal diagnosis. Given the result for previous diagnostic studies, the most appropriate way to confirm the diagnosis is excisional biopsy. Okay,
Okay. Oh, for LSD, I have visual hallucinations and euphoria, euphoric mood. That's all.
okay.
Yeah. Mm, 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 mm. A 2-year-old girl brought to the office by her mom because of bloody drainage from her right ear that the mother first noticed last night when the patient woke up screaming and holding the right ear. The pain improved after the mother cleaned the ear with a cotton swab and gave the patient ibuprofen. But the mother noted dry crusted blood on the patient's right ear lobe and pillow when she awoke this morning. The patient also has a 3-day history of cough, congestion, and runny nose. She has no history of serious illness, no medication, 25% off for height and weight, and fine for BMI, 50%. Vital signs normal. Right tympanic membrane cannot be visualized because of seropurulent fluid in the right external auditory canal. The remainder of the exam is fine, including examination of the left tympanic membrane. Which of the following is the most likely cause of the patient ear drainage?
Acute otitis media is an acute infection of the middle. Acute infection of the middle ear usually spreads to the space via eustachian tubes from the nasopharynx. Acute otitis media classically occurs in children, often from viral or bacterial pathogen, commonly Streptococcus pneumoniae, Haemophilus influenzae. It presents with ear pain, often with fever and erythematous tympanic membrane with retrotympanic pus or a middle ear effusion. Recurrent or persistent episodes of acute otitis media may lead to inflammation of the adjacent mastoid bone, and a condition known as mastoid, that is spontaneous perforation of the tympanic membrane, may occur, which typically results in acute conductive hearing loss, bloody or purulent otorrhea, often dramatic elevation of pain. Tympanic membrane perforation is an indication for treatment with antibiotics and typically with the fluoroquinolone or with amoxicillin or clavulanate. Most tympanic membrane perforations heal spontaneously without surgical intervention. Okay.
Can you read A, C, and D?
Yes. Basilar skull fracture occurs following significant cranial trauma, presence with hemotympanum and battles and retroauricular ecchymosis. Mm, Otitis externa is commonly known as a swimmer's ear. Presence with mild external ear, watery discharge, swelling, erythema of the external acoustic neutrous. Treatment includes topical fluoroquinolone, ciprofloxacin, or ofloxacin ear drop. Traumatic injury to the external auditory canal may occur following manipulation of the ear canal with a finger or cotton swab. This patient's history of pain and bloody drainage from the ear preceded manipulation with a cotton swab, suggesting that spontaneous perforation of the tympanic membrane secondary to otitis media is more likely. Okay.
Okay, next. 20 men comes to the student health services on his college campus because of painful urination and scant urethral discharge for the past week. He says that he has had no fever, chills, or back pain. For the past 6 months, he has engaged in unprotected sex with one partner. He has no history of STI or other disorder and takes no medication. He appears well, temperature fine, pulse fine, respiration fine, BP fine. Exam shows no cost of vertebra and penile lesion, no cost, yeah, severe angle, tenderness, penile lesions, or expressible discharge. Urinalysis shows no RBCs, some white blood cells, and no CAS. Throat cultures are pending. Which of the following is the most appropriate management at this time?
What is your diagnosis?
It's probably a STI. It has some protecting sex.
With
Must be a
one
STI.
partner.
But it's unprotected.
Okay.
And then he
So,
has
oh,
discharge.
yes, discharge is important. Painful urination and scant urethral discharge. So we will give the combo like chlamydia and gonorrhea.
Mm-hmm.
So that is chlamydia, trachomatis, and Neisseria gonorrhea can cause sexually transmitted infection, urethritis in men. Risk factor for STI include adolescence, multiple sexual partner, or and not using the barrier contraception like condoms. Urethritis typically presents with watery discharge or diarrhea. Infection with chlamydia trachomatis frequently asymptomatic. The diagnosis is confirmed by nucleic acid amplification test, prompt identification and treatment of the STI can prevent the spread of reinfection or infection and prevent complications such as PID and sterility. Empiric treatments is appropriate for a patient presenting with symptoms suspicious for STI. Combination therapy with intramuscular ceftriaxone or oral azithromycin is the most commonly used regimen and provides good coverage against Neisseria gonorrhea and chlamydia trachomatis respectively. Okay.
Yeah. Next. 62 woman comes to physician for PPD skin test prior to beginning volunteer work at a school. She has hypertension treated with thiazide and osteoarthritis treated with acetaminophen. She was born in the USA and has using contacts. No smoking, alcohol, or drug. Physical exam shows no abnormality. PPD skin test produces 6 millimeters of induration at 42 hours, 48 hours. Results of the liver function tests are normal. Chest X-ray shows no abnormality. Which of the following is the most appropriate next time?
Provide uh, clearance to begin volunteer work. Okay. Mycobacterium tuberculosis. Mycobacterium tuberculosis is a slow-growing mycobacterial infection. Mycobacterium tuberculosis is a slow-growing mycobacterial organism transmitted via respiratory secretion. It presents with primary latent or reactivation patterns in primary disease, so patients presents with subacute fevers, weight loss, night sweat, malaise. Latent TB can occur as the organism proliferates within the macrophage and is maintained within the caseating granule. PPD skin testing stimulate the T cell driven by type 4 delayed type of hypersensitivity reaction against subdermally injected tuberculin antigen. A common cause of false negative PPD testing includes a prior vaccination with BCG vaccine, percenters for disease control and prevention guidelines. In duration exceeding 15 millimeter is considered a positive result for a PPD skin test in patients with no risk factors for tuberculosis. In duration exceeding 10 millimeter is considered for a positive test result for high risk patients such as recent immigration from countries where tuberculosis is common, IV drug abusers, residents and co-workers in a high risk congre- congregate settings such as prisons, homeless shelters, nursing home facilities, or those with a particular medical conditions such as silicosis, diabetes mellitus, chronic renal failure, among others. In duration greater than 5 millimeter is considered Positive in patients with HIV with recent contact with tuberculosis positive patient with organ transplantation immunosuppression. This patient's test is negative for her dermatographic and she should be provided clearance to begin volunteer work.
Okay. Next. 42 men comes to the ED because of 2-day history of nausea, vomiting, and malaise. He has bipolar disorder, herpes 2, and chronic shoulder pain secondary to turn rotator cuff injury sustained 7 years ago. Medications have valproic acid, sertraline, acyclovir, hydrocodone, acetaminophen, and Docosahexac. He does not drink alcohol or use illicit drugs. Temperature fine, pulse high. Um, BP fine. Physical exam shows dry mucous membrane. Abdominal exam shows tenderness to palpation. Mental status exam, he has dysphoric mood and congruent affect. Labs, leukocyte count is fine. AST and ALT, I believe they are fine. Let me double check. ALT is high and AST is normal. Amylase is high. Which of the following medication is most likely to cause this patient current symptoms?
So this patient has dysphoric mood, like euphoric mood, like bipolar disorder. So mood stabilizer is the drug of choice, isn't it? Lithium,
Mm,
carbamazepine, sodium valproate, lamotrigine. These are the drugs.
mhm. Oh, they're saying he takes. They gave you the drugs he's taking. He's taking valproic acid.
Valproic acid is an anti-epileptic or mood stabilizer that is used to treatment of schizoaffective or bipolar disorder, drug-induced acute pancreatitis.
Bless you.
Sorry, drug-induced pancreatitis is a rare. Okay, drug-induced pancreatitis is a rare adverse effect of valproic acid that is idiosyncratic or not related to the drug doses or duration. The mechanism of the adverse reaction is known but possibly related to reactive oxygen species in induced endothelial damage within the pancreas for patients in whom valproic acid induced pancreatitis is suspected. Other possible cause of acute pancreatitis should be excluded. In the majority of the cases, pancreatitis is self-limited and it resolves like discontinuation of the drug. Other idiosyncratic valproic acid reaction include hepatotoxicity, bone marrow toxicity, alopecia.
Okay.
Is there
Next.
anything about valproic acid?
I feel like yeah. So maybe not. I feel like there was like I could see the pancreatitis and the neural because it also causes neural tube defects, right?
Yes, the valproic acid causes neural tube defect. Yes. So
So
in
yeah.
pregnancy we avoid these drugs.
I feel like I saw it somewhere, but never mind. I think the pancreatitis and the neural tube defect are the one that are shown on sketchy, not the other things.
Okay.
Okay. Next. 72 woman comes to office with her son for follow-up exam. She was diagnosed with Parkinson 8 years ago. She says her health has declined a lot during the past 6 months. She feels weaker and has had increased difficulty walking. She has stopped attending weekly luncheon with friends. The patient's son says his mother sleeps poorly at night and naps frequently during the day. He has to encourage her to eat and take medications. Patient medications are carbidopa, levodopa, donepezil. She appears sad and tearful as she discusses her difficulties. Exam shows a mild resting tremor of the hands. Mild bradykinesia. When asked to stand and walk from a seated position, she moves slowly and pushes on the arms of the chair with her hands. She takes steps with no agitation but walks slowly. Which of the following is the most appropriate next step in pharmacotherapy? Hmm.
What is her problem?
Mm-hmm. Seems like her medication is not doing. She's slower. I don't know.
Okay, Parkinson disease is a progressive neurodegenerative disorder caused by degradation of the dopaminergic neuron in the substantia nigra. Symptoms are associated with imbalance of the dopamine and acetylcholine, resulting in the characteristics findings of bradykinesia, resting muscle rigidity, bradykinesia, resting muscle rigidity, and postural instability. Psychiatric disturbance, sleep disorder, dementia are common complications. Psychiatric disturbance, sleep disorder, and dementia are common complications in addition to prominent major symptoms. In addition to prominent major symptoms, depression is depression is a common in elderly patients with Parkinson disease and other types of dementia such as Alzheimer in patients with 2 or more weeks at least 5 of the following symptoms: depressed mood, anhedonia, decreased interest in socializing, guilt or worthlessness, difficulty concentrating, suicidal thoughts, and neurovegetative symptoms, decreased energy and sleep disturbance, appetite disturbance. In addition, disturbance. In addition, patients with Parkinson disease may present with worsening motor function while experiencing depression. Depression are particularly increase the risk for suicide. Treatment for depression consists of pharmacotherapy with SSRI or atypical antidepressants or mirtazapine may particularly use in patients with insomnia. Useful in patients with insomnia because of its sedating side effect and those with appetite loss of diarrhea. Cognitive behavioral therapy is useful in managing the. Okay, got
Can
it.
you read? Okay. Can you read
Yes.
B, D, and E?
Add resazelin in the medication regimen. Add resazelin in the medication regimen is incorrect. Resazelin is a monoamine oxidase inhibitor. Monoamine oxidase inhibitor that is useful for treating early Parkinson disease. It is less useful for treatment for depression and associated Parkinson disease and should be used with caution if combination with particular antidepressant such as SSRI because of risk of serotonin syndrome. Increase the dose of carbidopa. Levodopa is incorrect. Carbidopa, levodopa non-selectively increase the dopamine concentration in the basal ganglia and limbic system, leading to improvement of Parkinson disease symptoms. While raising the dose of the carbidopa and levodopa is useful for treating, while raising the dose of carbidopa and levodopa is useful for treating residual symptoms of Parkinson disease, it does not treat depression, and higher doses are associated with increased risk of psychotic symptoms. Okay, okay, E. Sorry,
Mhm.
increasing the doses of donepezil is incorrect. Donepezil is an anticholinesterase inhibitor that indirectly increases the concentration of the neuromuscular acetylcholine. It is not useful in treating Alzheimer dementia, but also improves the cognition. In Parkinson disease dementia, it is not useful for treating depression. Okay.
Okay. Next, 32 premigraphied, a woman at 10 weeks gestation comes to physician for first prenatal. She conceived after in vitro fertilization. 3 years ago, bicornuate uterus was noted on exam for primary infertility. She's otherwise healthy, doesn't take medication, only the prenatal. She weighed 110 pounds prior to pregnancy. BMI was 19. She has had 2 pound weight gain during her pregnancy only. Her BP is fine, I guess. Exam shows the uterus consistent in size within week. This patient is at greater risk for which of the following pregnancy complications?
Preterm delivery infertility can have multitude of the causes, including hormonal disorders, inflammatory disease, structural abnormalities, autoimmune disease, clotting disorders, and lifestyle factors. Infertility can be primarily uh, in patients who have never conceived, or secondary in patients who have previous conceptions. Regardless, it is defined as inability of the couple to conceive after 12 months of regular intercourse, or after 6 months of intercourse in women age over 35. The evaluation of the infertility includes history and physical examination, as well as lab evaluation, imaging studies, potentially laparoscopy. Common causes of infertility include ovulatory dysfunction and endometriosis. Congenital or structural uterine abnormality as seen in this patient can lead to infertility. A bicondyate uterus is caused by failure of the paramesonephric duct to fully fuse, resulting in resulting in resulting into completely or partially separate uterine cavities. Because of this, there is diminished area for egg implantation, as well as placental and fetal development, which predispose the patients to infertility and recurrent pregnancy loss. A bicondyate uterus also increase the risk of preterm delivery, fetal growth restriction, and malpresentation. Therefore, these patients are at high risk for preterm delivery given an anatomic uterine variant. I
Okay,
don't
one.
understand.
Oh, uh, have you seen the bicornuate uterus?
Yes.
Yeah. So there is no space there um,
Okay.
for the placenta for the baby to grow and stuff. So it's probably gonna. I don't know how to
End up
explain
in
it.
preterm delivery.
Yeah, the baby is gonna grow more than the space that he has, and it's gonna try to get out, kind of thing. That's kind of what they're saying.
Like uterus is separated in two portions.
Uh huh.
Okay.
Mm-hmm. But you've seen it, right? The
Y-
bicornuate.
yes, I have
Uh-huh.
seen it.
Yeah. So uterus, yeah, he's gonna uh, separate. Like there is no space, so the baby's gonna try to uh, get out quicker. Okay. You want to continue or you? Because it's already 11.
No, we can only two questions left.
Okay. 22 man with alcohol use disorder comes to the physician because 3 week history of weakness in his right hand. His symptoms began after drinking a bottle of whiskey. He has no history of serious illness, no medication, drinks a lot. On the exam of the right upper extremity, motor strength is 2 out of 5 in the supinator. Wrist extensor and finger extensor strength is 5 in all other um, muscles. Sensation to pink is decreased over the dorsum of the right hand from the wrist to the base of the thumb and index finger. Which of the following is the most appropriate next step in diagnosis? Oh,
Thumb and index finger. Then which nerve?
thumb and
Median.
index.
Thumb and index. Okay. Dorsum of the. Okay, the radial nerve is a nerve of the brachial plexus. Is comprised of the afferent and efferent of the C5 and T1 nerve root. It courses through the axilla down the posterior shaft of the humerus within the spiral groove Then along the posterolateral aspect of the forearm, the radial nerve supplies the motor fibers to the triceps brachii and the extensor muscles within the posterior compartment of the forearm, and sensory fibers to the dorsum of the forearm, wrist, hand. It does not innervate the intrinsic muscles of the hand. It is prone to the injury mid-shaft humerus fracture as it runs near the humeral diaphysis within the spiral groove. Injury to the injury to the nerve presence with loss of function or structure distal to the injury. In the case of the patient, the weakness of the wrist and the finger extensor suggests injury within the axilla or arm. In case of acute intoxication, prolonged compression of the nerve against a hard surface is a common during periods of unconsciousness. Electromyography and nerve conduction study are most appropriate for determining the diagnosis of the radial nerve palsy. Okay.
Okay, next. One day after delivery, One day after delivery of a healthy newborn, 22 women, gravida 2 para 2 has fever. Pregnancy and delivery were uncomplicated. Temperature is high, pulse is high, respiration high, BP normal. Exam shows normal lochia rubra. The uterus is tender and the fundus extends to the umbilicus. The leukocyte count is high with a shift to the left. While awaiting results of additional life studies, which of the following is the most likely cause of?
Okay, it's E. coli causing endometritis. Endometritis is an acute infection of the endometrium, uterine endometrium, that commonly occurs after delivery. Patients typically present with fever, tenderness, and of the uterine fundus and mucopurulent vaginal distress. Lab studies commonly shows leukocytosis, and endometritis is caused by the ascending bacteria from the vagina, and risk factor for development include cesarean delivery, prolonged rupture of the membrane, advanced mental age, multiple cervical examinations. Endometritis is polymicrobial isolated E. coli, Enterobacter, Enterococcus, bacteroides, Clostridium. When severe, it can cause bacteria and sepsis, and treatment with IV antibiotic is required. Okay,
Okay, we're
okay, we
done.
are done. Okay,
I'll see you tomorrow for the 14.
okay.
Bye.